Hello everyone and welcome to the latest A Spotlight on interview. Today I'm joined by Marshall Summar and we're going to be talking about rare diseases. So Marshall, if you could please introduce yourself and tell everyone a little bit about what you do.
Poppy, thank you so much. My name is Marshall Summar. I work in Washington, D.C. at Children's National Hospital, where I run the Rare Disease Institute and the Genetics and Metabolism program here. I've been doing this since about 1985. My career was split between Vanderbilt University and then Children's National in Washington. The goal of what we're trying to do here is build out new clinical models to take care of patients with rare diseases. It's a very exciting field, a very exciting time. I think we'll have lots to talk about.
That's so exciting. Thank you. And can you give us your definition of a rare disease? What makes it rare?
So that's actually a really good question. So it actually depends on where you are. If you're in the European Union, they use a 1 in 2,000 definition, which works out to about 1 in 2,000. In the United States, we use a definition of 200,000 patients or less, which works out to about 1 in 1,600. And interestingly, different countries do it different ways. Taiwan has a list of rare diseases. So if it's not on the list, it doesn't occur. So theirs might be more like 1 in 100,000 or 1 in 50,000, things like that from their population. A good working definition, though, that I've used over the years is a rare disease is uncommon enough where a general practitioner might have heard the name, but has probably not encountered many patients or maybe only a single patient with that condition and really wouldn't be expected to know the details of complex management for those patients. So that's sort of my working definition for that.
It's an excellent working definition. And I'm assuming as we find more people with conditions,
Right.
What are some of the factors affecting the prevalence of rare diseases? Are we seeing an upwards trend as we diagnose more?
Oh, Poppy, we absolutely are seeing an upwards trend. There's actually 3 things going on. One that is actually taking place in the more general fields of medicine is molecular genetic diagnosis is actually taking common conditions and then broken them down into smaller genetic subgroups. Breast cancer is a great example. There are now 30 molecular subtypes based on DNA and genetic changes in breast cancer. Those groups actually start to fall into a rare disease level of incidence. So you've got your incidence, how many per thousand, then you've got your prevalence, how many are existing in the population at a given time. Prevalence, what we're seeing with all of the new therapies for rare disease and the consolidation of treatment protocols, 3 good examples. Down syndrome, which is borderline rare disease, but it actually is heading that way very quickly. In the 1980s, life expectancy was about 27. Now it's approaching 60. So your prevalence has gone way up. Cystic fibrosis used to be lethal, usually typically in the teenage years. It sort of adds 1 year to life expectancy every year because we don't know what the back end of it is. So prevalence again has gone up. Sickle cell anemia, another great example. Used to be one of those diseases we would see death early, first, second decade. Now we're seeing these patients longer and longer and longer. Again, we don't know what the back end of that. So the incidence of these conditions in rare disease really has not changed that much. These patients have been here. What molecular genetic diagnosis has allowed us to do is identify more and more. So I got to work with as part of the Human Genome Project back in the 1990s. And before that, we could accurately diagnose a few dozen things. Then with 2000, when we got the draft sequence of the human genome, suddenly we were able to start applying that. And as the cost of sequence analysis has come down, we're identifying new conditions where we're linking a molecular genetic change to a clinical phenotype, in other words, a disease, at the rate of 10 to 12 a week. So it makes this unlike any other field of medicine. These patients always existed. We just did not know what they had. It was a patient with a learning disability or a patient with, some other thing that we sort of thought was sort of general, maybe might be genetic, but we didn't have a way to test them. Now we're finding more and more of these things and are able to start to determine the underlying diagnosis.
That's fascinating. And you use the word there, a unique model of medicine.
Yes.
What are other factors that are making rare disease such a unique space?
Yes. So in many ways, rare disease is kind of coming out as a field of medicine where the rules are a little different from common. And for my colleagues out there in the field, I do not mean this with offense to your fields. It's just we've got a different set of things to deal with. One is our incidence is very small. In fact, for most of these diseases, we don't even know what the incidence is because there's so few patients. And these are genetic in origin, which makes them lifetime conditions. Those genes are there from before you're born until, when you die and after. So when you look at that, you're looking at lifespan diseases, which can manifest differently at different stages of life. The next part of that adds a layer of complexity is we see a lot of what is called genetic heterogeneity. What that means is the genetic change that causes that disease can either be very mild or can be very severe, which then gives you a clinical phenotype or the expression of the disease that can vary across the age span. A great example are urea cycle disorders, defects in ammonia and nitrogen processing. Patients can present in the first 12 hours of life with severe hyperammonemia, or the patient may not present until their 80s when a series of environmental exposures, things like that, have finally sort of brought out that underlying genetic defect. Same genes, same biochemistry, but just different degrees. So that's another layer of complexity. Another is that we know very little about these conditions. We have not much data on the incidence, and our classic models for doing consensus treatment for these patients really fall short when you start looking at the rapid discovery rates and everything else. The classic model is your Delphi criteria, where you want large meta-analysis of population-wide, say something like hypertension, where you have tons and tons of data that you can analyze to your heart's content. In rare disease, we may have a dozen patients. We had one disease where we were doing a clinical study and a clinical trial. We only had 5 patients. And I remember the statistician asking me, saying, well, that's not a representative sample. And my reply to him was, it's not a sample, that's the entire population. And so you have to think of these things differently from the standpoint of what's your clinical evidence? How do you do evidence-based medicine? Because your evidence tends to be very thin. There's an interesting thing we've observed too. When you look at rare disease, you don't get the big meta studies, you don't get the big, large collection of data patients at a center because they don't exist. When you look at your next 2 levels of evidence, one is published literature and then the other is expert opinion. Published literature in rare disease is a little peculiar because you'll often have a report of the first few patients, but the only thing people can really get published after that are the exceptions to that. So if you use that to base your treatment guidelines on, you end up teaching to the margins. We've actually got a really fun project. Maybe we can circle back and talk later about how we address that and how do we actually capture some of that expert opinion for that. So these are all ways. The next thing that I would say is a really unique feature of the field is it's one of the closest interactions between the patients and families and the physicians. Our families are often the world's expert on their version of their rare disease. Many times physicians will not have seen this before. In fact, quite often they will have not seen this before. And the family often has to be the bearer of the information about the disease. And if the physician's in the right mood, can listen to them and actually learn about these things. So the partnerships between the care providers in rare disease and the families, I think, is as close, if not closer, than any field of medicine. So lots of ways it's different. I mean, it's got a lot of the same basics as general medicine, but I think there's some real distinct features here.
Absolutely. And for a bit of a timeline, can you give us an overview of the types of therapies we've seen over time and which are the growing and emerging options?
So I think let's go back in time a little bit to 1983 and the passage of the Orphan Drug Act. And I don't have the exact year but the European Union obviously passed something very similar. Britain has something very similar. Before that, there was almost no incentive to develop therapies for rare disease. A large pharmaceutical company really would not be incentivized to do that. It's arguably probably the most effective incentive program that we've seen, at least from getting industry to participate in the field. Just looking at the data for last year, 50% of the new chemical entities approved by the FDA were for orphan designation, in other words, rare disease. Now, about half of those are for cancer, but even with that, that means 25% of the drugs coming out of FDA for approval every year are for rare disease. That is a startling increase. There are good incentive programs, things like that. So what type of therapies are we looking at? First off, there are your drug and pharmaceutical therapies. That's obviously where a lot of emphasis is. That's where a lot of the development is. But we have to remember that for many of our patients, there's probably never going to be a drug, or there may not be much of that. But we've really started working on how do we maximize intellectual development? How do we maximize quality of life for our patients? And that's, again, where that partnership with the parents and families works, but also with the educational system, all of these different things. Down syndrome is a good example. It used to be folks would say, oh, the child with Down syndrome will never read, really won't be able to socially interact. And we never gave those kids a chance. So what we're finding now is we sort of do the opposite. We sort of train to failure, so to speak. We try to allow these patients to do as much as they possibly can, provide really positive learning and social situations where they can grow and develop and really become their own person. We're finding the results really do improve that way. So that's one thing. Now let's talk about our kind of classic drug model, and probably some of your audience will be interested in this. We start with, you have your small molecules. That's kind of your classic drug. We try to find from the genes or the things we know about that disease, a place where we can put a lever in and improve some outcome. And those have been around, and you know what, that's still actually a very viable development pathway, because tissue penetration with small molecules is pretty good. Then we come to the age of the enzyme therapies. And that really started back in the 90s, when we were able to make recombinant enzymes that would carry out the activity of a missing enzyme. And these have typically been in the lysosomal storage diseases. Those require infusions of enzymes on a regular basis. There are immunologic issues, but it's been a mainstay of therapy in diseases like Gaucher's, Pompe's for many, many years. Now we have some new generation things coming along. And I'm going to get to gene therapy in a second. We'll come back to that, don't worry. We also have things around substrate reduction. So if you're building up a toxin and you can't quite get rid of that, can you go upstream to that? Tyrosinemia is a great example of that. By building a metabolic block higher in the pathway at a non-toxic level, you prevent the formation of a toxic substance later on down the pathway. And they're doing a lot of work with that in lysosomals and other fields as well too. Dietary therapy for, say, the essential amino acid phenylalanine in PKU, removal of phenylalanine from the diet actually can be highly effective therapeutically for patients with PKU, something we've been doing since the 1960s and before that. So, dietary therapy and manipulation are a big part of this too. Now let's get into our nucleic acid therapies. Let's start with messenger RNA. That's something not many people were thinking about, and then we all got a big dose of it last year. In fact, a lot of us got a big dose of it in our arms. That's adding the sort of what I would call the working copy of the gene that the cell uses to make the protein. Messenger RNA therapies are growing pretty quickly. We found they're pretty safe. I think we just did the largest clinical trials experiment in history, kind of showing that. And while there's a few reactions, not so many actually. So messenger RNA therapy is coming along for metabolic diseases, probably where it's going to be very impactful. Then we get into the genome and the productions of RNA, things like that. And we have things that will affect the splicing of messenger RNAs. Let's say there's a defect, but we can get that to splice out or to splice in. That's one thing. So you're seeing a lot of those in Duchenne's, places like that, where they're trying to manipulate the messenger RNA after it's made a copy from the DNA and try to get that one so it's got a good functional copy there. So that's one strategy. The other, sometimes you don't want to make the protein that's causing the problem. So we'll use antisense oligonucleotides, things that will go in, bind to the RNA or bind to the gene and prevent production of the messenger RNA. So lots of different things there. Now let's come to gene therapy. So there's two kind of branches. One is vehicles that will deliver a normal copy of the gene into the tissue. It may or may not integrate into the DNA, but will sit there and make things. And the most common one that's being studied these days is the adeno-associated viruses. And they're different viruses that will infect different tissues, so you can get some specificity there. What we've run into those is you kind of get a one and done. Because the human immune system is wonderfully great at recognizing foreign viruses, making antibodies to it, And then the next time that virus shows up, kind of going, no, not getting in. So one of the things we've run across with these type of viral gene therapies is one dose enough? Is that going to wear out with time? Let's say it's a liver-based therapy. Liver is a dividing tissue. If we dose once, later on will, as the liver divided, kind of dilute the effect. Same thing with bone marrow, things like that. So gene therapy in tissues that don't divide a lot, like muscle and brain, may be more effective than it will in these others. Or it may be that we just simply buy some time by doing our patients early, getting them through those rough few years. Remember, biochemically and growth, those first 4 or 5 years are massive compared to the rest of your life. So it may just be getting people through those years. And of course, the one everyone's kind of like, ooh, this could be really interesting, are the CRISPR technologies, gene editing. And this is one that's evolving quickly. It's not quite ready for prime time. It's kind of interesting. I keep hearing the term 5 years from now. That was the term we started using with gene therapy back in the 80s. So 5 years kind of that's distant enough, but soon enough so people I don't know what the time frame is on CRISPR. Obviously, if you can change the genome to get rid of the change, the deleterious change, that's a good thing. What everyone worries about are off-target effects. So with gene editing, are you going back? Yes, you got the one you wanted, but did you get another that might be an oncogene or something else that could cause problems later on? And most of the worries around what I call cell cycle regulators. If you interfered with a cell cycle regulator, might you turn that tissue into a tumor? And while risks may be low, but if you're doing that to billions and billions of cells, the risk may actually become appreciable. So I think I'm cautiously optimistic about the gene editors, but I think it's one of those things that you just gotta keep an eye on. And also there are the efficiency issues. How many of the cells can you actually revert to a normal phenotype? And for some of them, do you have to do both copies, which suddenly lowers your probability? So that's a stay tuned, but very interesting. Obviously, there's a lot of effort going in to make those systems more efficient, more specific, more portable, so to speak, so it's easier to get in. Most of the technology is derived from bacterial systems, and bacterial systems can afford to be sloppy. So, if a bacteria gets a mutation, so what? There's 10 billion right behind me that, got it right. When you're doing, eukaryotic or human cells, you want to be a little more careful than that. So I think we'll probably see some refinements in the technology before that really moves forward. That was a long answer to a short question, but that's kind of sort of a review of what's going on.
It's an excellent review. Thank you so much for diving into the opportunities as well as the limitations there. And on limitations, what are the biggest obstacles you face when trying to approach treating rare diseases? Sure.
It kind of depends on where you are. So I work in a lot of different places and talk to a lot of different folks. Let's talk about healthcare systems first, then we'll talk about provider supply, and then we'll talk about the diagnostic lag or things like that. So let's talk with healthcare systems first. Large healthcare systems, particularly national ones, are not always well designed to deal with rare disease. In some ways, you can almost say that rare disease, until other things like infant mortality, death in early ages, get below a certain level, rare disease really doesn't get that noticeable. So in a lot of countries where there are a lot of other challenges, rare disease is not something that's popping up too much. In your, what I call kind of first or top end medical systems, it depends on the system. If it's a capitated system, so you have a national healthcare policy where you're going to take care of a certain number of things, rare disease always slots in last, it seems. And I've seen this in a number of systems. And it doesn't fit the normal pattern. They base a lot of those systems on big data from lots and lots of patients, so they can make rational choices about how to allocate. The individual therapies for rare disease are quite expensive. And so they're caught between this, well, we like to take care of you. You don't really fit our model where we've got, 1 million people's worth of data about what to do with this. And this therapy is very expensive. So we're not sure how we're going to slot it in. And oh, by the way, we've now spent our annual budget on the things we already knew about. So we're not sure what to do with you. So that's one model. The next are the kind of hybrid models where you have public and you have private insurance, things like that. Those systems might actually be doing a little bit better with rare disease, since a lot of those patients are responsible for the care of those patients. They look at sort of the area under the curve. Let's take gene therapy, for instance. We're actually finding some, I won't call it eagerness. No one is eager to spend a couple of $1 million, but at least pretty good acceptance of employing gene therapy for these diseases. While it's very expensive right there, it changes your area under the curve for the treatment of that patient, plus improving your quality of life, which to me is a big deal. But from the payer standpoint, you may actually recognize a cost savings by spending a lot of money at one point, later on by not having to spend as much down the line. So there's a lot going on around that, and they can afford, well, not afford's not the right term. They can look at those things at these little small levels because they are responsible for the healthcare for those patients. So I actually see a little bit more flexibility in those systems than I do in some of the national ones. So let's set that aside. Now let's talk about workforce. Workforce is a challenge. The fields that care for patients with rare disease are typically non-procedural fields. Now let me explain why that's important. In most healthcare systems and models, a lot of the financial emphasis is on surgeries, ICU beds, procedural-based, laboratory-based, things like that. Thinking about a patient actually doesn't pay in almost any medical system. It's rewarding beyond belief. I love doing what I do, but it also doesn't have a great financial model. You can't gauge or somebody trying to be smart while taking care of a patient. So that's one reason it tends to be, we have fewer people in the field than I would like to see, because the financial incentives are not as great. In a national system, you actually still see some of the same things there as well too. So we have a dearth of providers. One thing we're finding too, as students are graduating from medical colleges these days, a lot of them are coming out with a lot of debt, particularly in the United States and some other countries. So they actually have to look at fields that may have a better pay line, things like that. So we try to get a lot of folks interested in the field. We've actually had some successes. It is a fascinating field. I mean, the patients are wonderful. It's intellectually stimulating. So any of you out there who are trainees, please, dear goodness gracious, it's a great field to be in. But we do have workforce issues. With genetic counseling, which are our professionals who go through and work with the patients, explain the testing, we're actually in competition with industry. The large sequencing houses, the companies that provide commercial sequencing, hire a lot of genetic counselors. So the counselors we would normally have in our clinics helping diagnose, many of them are actually in the industry side right now. I'm thinking that settles down over the next few years. But also part of it's our own fault in the field. We have not done a great job of providing tools and systems for primary care providers and frontline practitioners to be able to diagnose rare disease well. So one thing we're working on right now is building out protocols, we call them scenario-based protocols, where when a primary care provider is presented with a patient, is just, this one doesn't look like our normal patient, they actually have some recipes they can follow to help that patient get towards a diagnosis. It shouldn't be that you have to wait a year to see the person. You can do it. And that's the typical wait time now for rare disease physicians and medical geneticists. There's ways we can push that stuff forward. And, with the digital environment, certainly there's a lot of those things you can do. And that leads into what I call the diagnostic odyssey for patients. That's where patients, everyone quotes this 7 year. It's actually not quite 7 years. It's less than that. There are some diseases, though, where it can often go a decade or more not being diagnosed, even though the patient has symptoms. And there are a lot of approaches to that. One is trying to get those diagnostic tools pushed closer out to the front line. You can talk about, everyone talks a lot about using sequence analysis in newborn screening. My opinion, and I would say that of a lot of my colleagues, we're not ready for that yet, because we don't know how to interpret so much of what we find in the human genome. So our false positive rate, that's the one where we say something might be going on, but nothing's really going on, would be enormously more than the true positive rate of things we would catch. So think about that for a parent. Half the time when they've got a new baby, someone calls and said, well, we found a change that might actually kill your child, but we're not really sure. But hey, call us if anything funny happens. That's not going to be particularly reassuring.
Definitely not. And I kind of want to dive into that patient first that you've peppered throughout today. What can other areas of medicine learn from the rare diseases sector as we shift our systems to patient-led more widely? And with these sometimes complex diagnoses, we're really bad at understanding risk, and empowering the patient often comes with more responsibility on them as well. So what challenges do you see and what opportunities?
I tend to see opportunities more than challenges, so we'll take it that way. What I would say is, in rare disease, the patient has to be a partner because they know more often about their own version of it than anyone else. How I think that translates into the rest of medicine is it's kind of going against a trend we've had where we want to lump everyone into an enormous group, figure out the best way to treat that enormous group. But what we actually find is that enormous group is made up of individuals. And as molecular diagnosis continues to evolve and improve, we're going to find changes that will impact even routine healthcare and vary how you do things. Do you do this surgery here for the patient with the joint problem, or do you wait because they may have better regenerative capacity than someone else, and let that go forward? I think we're going to start to see those kind of changes work their way in. Some of it's just getting the system used to that, getting used to the fact that you've got 25,000 plus different genes. Those all interact together. Even if you've got a gene change that gives you a significant impact on a system, you still got all those other genes that are around there. So it really does speak to the fact that these patients each have an individual presentation. There'll be some commonalities. That's one of the ways we can spot what's going on. But you have to actually treat that patient as an individual, and you have to be flexible about your therapy. The one size fits all does not work well in rare disease because the variability in genetic heterogeneity, expression, phenotype, all those things means you may start with kind of a generic, here's how we're going to address this. You're going to end up having to tailor it for that specific patient to meet their needs, whether they're biochemical or other needs, so that you can kind of optimize what you're trying to do. So cookbook medicine doesn't work as well here, but you have to start with a cookbook. You got to start with a recipe, but you've also got to monitor carefully and adjust and adapt. So I would say that's one of the ways it's very different. And one of the things I think we're going to be teaching the other field, as more common conditions split into small molecular subgroups, you're going to have to continue to start tailoring therapies for those breakdowns in those smaller groups. And like I said, they look a lot like rare disease when you start doing that.
Thank you. And to link to your point about data earlier this year, we had a Californian biotech announce their $100 genome. That's making data more easily available than before. So what do you see being the challenges and benefits of reduced costs in this genetic sequencing?
I am all for reducing cost in there. The thing to remember is actually the sequence itself these days is the least expensive part of sequence analysis. So here, let me explain. If we do a whole genome, we're sequencing several billion bases of DNA. Actually, I don't know if your viewers know this, but it was only a couple of months ago that we actually sort of considered we had a complete human genome sequence. We had most of it, but there were some really hard to sequence parts we didn't get until about 3 months ago. How do I put this? If I sequenced both of us, I'd find probably about maybe 10 million variations between us. Let's say one of us has a disease and the other one does not. Which of those 10 million caused the disease? So there's a bit of what we call interpretive dance involved. If it's something we've seen before, that's a lot easier. The delta F508 mutation, the CFTR gene, is known to cause cystic fibrosis, tons of data. That one's pretty easy. But what if you find a change in that gene that no one has seen before? You can make a good story that would cause a cystic fibrosis-like pattern, but you haven't necessarily established direct causation from that gene. So you're going to hear the term variants of unknown significance thrown around a lot. And those variants of unknown significance are what really will throw that out. If I sequence any of us, I'm going to find some serious changes in some genes. But are they relevant to the clinical picture in front of us? So $100 genome's fine, but you still have to analyze the data and see if there's actually a link between the changes you find. If not, I guess one way of putting it is we've got a giant monster-sized puzzle with lots of pieces, and we're starting to fill in some of the edge pieces. We've got to fill in a whole lot more before you can really see the impact of some of the cheaper sequencing. I mean, I'm seeing whole genomes down as much as $3,000 or $2,500. The chip itself to do the sequence is quite cheap, relatively speaking to these things. It's the sequence analysis, because we still require a human knowledgeable intermediary to say, okay, this makes sense that this variation might link to this. But the most common answer in human sequence analysis right now is maybe. We very rarely give you a, yes, this did it. This is exactly what happened. No, you're completely normal. What you get is a maybe. This variation may have caused this. There's a high probability. It's one of the reasons we like to sequence families as much as possible, as opposed to an individual. We want to say, okay, did this come from the parents? Are there any siblings with the same change who don't have anything or may have the same thing? So we're still kind of feeling our way through. I think that's going to take a few years because it's a complex problem, but every day we fill in a little bit more of the puzzle.
That's fantastic. And we're almost to time. So I'd love to finish off by revisiting your fun project on expert opinion. And we can dive into that.
So you'll see this coming out sometime in the next year. We've got together a lot of folks in the field and said, okay, how do we solve this workforce problem and get some standard care to the patients? Anytime in any rare disease field, when we've gotten together and pulled together our best treatment practices, we improve outcomes. Cystic fibrosis is a beautiful example. Before there were any new drugs, simply pulling the best practices together almost doubled the life expectancy of the patients. So we have a program we're working on, actually with the same folks that built the REDCap program at Vanderbilt University, my old colleagues there, and this will be called RareCap. What it is clinically actionable protocols. So they're based around scenarios: acute presentation, confirming diagnosis, chronic management, impact on routine medical care, special situations like pregnancy, chemotherapy. What do you do with that disease in those situations? But very practical, what I call Friday night guidelines. So it's Friday night, the specialists have all gone home. Do you have something in front of you that you can use to do that? But we're taking a little bit of a different approach. So sort of think of, I don't know if I'm violating copyright here, Wikipedia meets Reddit. So you'll have a core protocol that kind of addresses that or what's known about the disease. But the people using it, who are registered users, you have to have some knowledge in the field, actually comment on the protocol and what they might do differently or what they think might improve it. The community that's using that actually can vote those up, down, make comments on the comments. It's very carefully moderated, so no flame wars allowed. But then you can actually use that to improve the protocol with time. So think of it as a real-time evolution of the way you're treating those patients, pulling best practices from all the people seeing those patients. Is it a 100% solution? Absolutely not. It kind of gets towards pulling in, though, and capitalizing on that expert opinion of the people that are working with those patients on the front line. And the nice thing is we can ramp this up to cover thousands of diseases, as opposed to waiting until 20 years until you've got published literature, and then you do a review of the published literature to see if you can determine what the best treatment outcomes. Then you find the published literature is self-contradictory, so you don't really know anyway.
Thank you so much, Marshall. I've learned so much. I can't wait to see what that puzzle ends up looking like, whether it's in the next 5 years or the next 5 years after that. And I'm excited to see where patient-led medicine will take us and the learnings we'll take from rare diseases. So thank you for joining me.
It's been my pleasure. Thank you so very much, Poppy.
Hello everyone. If you enjoyed this video, then make sure you check out some of our other videos in our series by subscribing below or going to our website, frontlinegenomics.com. I hope you enjoy.